Good evening. Thank you for coming. Uh, the first, at first, I will talk about the review of my Oxford procedure, and then move on to the talk about the dislocation. Because dislocation is a very serious program after the Oxford UKA. Anyway, very roughly, I will present the summary of the Oxford operation. This is a position. The perfectly operation should be can be done with the leg hanging position like this using the leg holder. Please make sure there is the space between the leg holder and the popliteus area to prevent the damage or the neurovascular damage. And someone is coming. Okay. And then open the joint and then make sure the cartilage status, especially for the medial side cartilage wear and lateral side normal cartilage along with the intact ACL. And this is the ACL grading system in normal synovial damage and longitudinal split. Their ACL intact functioning and friable and fragmented and absent. They are actually deficient. That is a contraindication of UKA. Then the first we should do the osteophyte removal. The first is remove osteophyte in front of ACL insertion on the tibial side. That can prevent the fluid extension. So after the removal of osteophyte, then it mostly can extend fully. Then next, the remove the osteophyte lateral edge of the intercondylar notch that can hurt the ACL in the future to prevent the subsequent ACL damage. You should remove and make the big space for the future ACL. And then insert the elevator between the PCL and medial condyle. That can make the space for the sagittal bone saw to prevent ACL, PCL damage. So sagittal saw can hurt the PCL. So prevent, you should make space here. And then mark the top of the medial tibial spine using the cartridge. This can act as the saw blade guide during the sagittal cut of the tibia. Then clear the medial condylar edge and remove the medial osteophyte on the medial condyle of the femur. This procedure is quite important because remnant osteophyte can push the MCL laterally, that can shorten the medial gap. So you should carefully remove the osteophyte completely, and after the removal of the distal end of the femur, then move on to the posterior side of the femur, preventing the MCL using the Z retractor. Using the thin chisel, you should remove the osteophyte completely between the medial condyle and the MCL. Then, sorry, then the sizing the medial condyle, and make sure the space to a millimeter that can equivalent to the previous thickness of the cartilage. So if the tip of the spoon is touched to the bone surface, it implies the size is too small. You should increase the size for the femur side. And this is the checkpoint. you need to trim that space. Then set the tibia guide. The tibia guide should be the parallel to the anterior tibia crest and connect tibia cutting block using the G clamp. Then clamp and fix the cut block, but never use the two media to hold because it can cause the fracture in the future. Please use the most lateral hold and make sure they're protected by so the upper surface of the cutting block is the cutting surface of the horizontal cut. Please make sure cutting line come to the center of the protector that protect the MCL. Uh, then change to the seam to the slotted one. Cut the horizontally. This the point is the tibia horizontal cut should be the two steps. The first is the posteriorly, and the second medially along the medial edge of the tibia plateau. So that can make your cut is complete, the perfect cut. So make sure if you worry about neurovascular and PCL damage, this horizontal cut tends to be too short, but can cause the fracture of the posterior edge of the tibia lateral that can lead to and the very unstable tibia tray. So it must complete. The cut should be the complete. To prevent neurovascular damage, you should make sure there's enough space between the leg holder and the pop the failure. Again, then sidewalk cut should be done on the previous part on top of the tibia spine, and that can aim to that should aim to the ASI's anterior tibia spine, iliac spine. Then after the removal of the tibia cutting fragment, then a femoral delivery guide to make sure the gap is enough or not. But it is sometimes tight, so maybe due to some reasons, if it is too tight, we have two choices. The one is the cutter posterior cartridge. This is recommendable because if you cut the tibial cut, we can reduce the bone volume to the tibial side. We should avoid it, especially for the Asian patient that has very small frames. So instead of the tibial recut, firstly we try to femur posterior cartridge removal using the chisel or the even the bone saw. And then insert from okay. Okay. And then insert IM rod. The entry point should be a slightly medial from the center of the intercondylar notch. And insert IM rod. It should be inserted only the two fingers, very light touch, never use the hammer because that can penetrate the bone cortex. If it is too tight, entry point or direction is not proper. So you should change the direction of the rod and try to insert again. And connect the rod and the tibia femoral guide using the linkage. At the time, you should make sure this femoral guide is placed at the center of the condyle. At the time, you should use the and the pinch the medial femoral condyle using your thumb and index finger. Make the drill hole and make sure the position of the hole that can that should be made at the center of the medial condyle. Then set the female cutting guide and cut. During the female cutting, you should hand down and place the tip of the bone saw at the lower surface of the female cutting guide. Otherwise, this saw can be kicked by the hard bony surface, so that can cause the very thin posterior female condyle cut that can shorten the medial gap, initial gap. So please prevent the kick of the saw blade tip by the hard bony surface. After the posterior condyle cut, you should do the first mill. So using the zero spigot until this bar is touched in the window. Then remove the corner bone using the chisel as here. After that, the second step is meniscectomy. At that time, you should be very, very careful not to damage the MCL, especially for the tibial side. If you cut the meniscus, looking upper side of the meniscus, you can hurt the insertion of the tibia side of the MCL. That should be avoided. So you should looking upper surface and lower surface and pull the both side using the forceps and using the knife. You should cut the meniscus. Then place the tibia tray trial, and this you should use a pull and push technique. Pull the T handle and push the tibia tray to for posterior cortex and tray to be flushed. Yeah. Then before the abrasion gap, you should remove the all retractor and gap aberration and compare the pressure gap and extension gap. The anomaly in the manual, this pressure gap should be evaluated in the 20 degrees inflection under the Vargas stress. But I strongly recommend make sure the gap only the 20 degrees, but also the full extension, because sometimes some knees in extension is looser. The gap is looser in the full extension. And then adjust the distal femoral cut using the mill and spigot. Then after the complete the milling, to set the tibia tray and make the keel slot using the T-saw, T-blast saw. And at that time, you should hold the pin by your hand and using the dohin technique, and never push this saw posteriorly up and down and up and go slightly posterior and down, up and up and down like the dolphin. Then after that, make sure this Q13 does not break the posterior cortex, and then insert anti-hinchment guide. At that time, never flex deeply, otherwise this slot can hurt the tibia cutting surface. And anterior bone cut and the posterior bone cut. Anterior cut and this is a posterior cut. Remove the bone cut to prevent the impingement. And this is the final trial, and make sure the space between the bearing and the arch wall of the tibia tray. And the cement preparation, make the cement anchor hole, and let's start from the tibia side and push the cement in the cancerous to oppose the cement penetration. That can prevent the loosening and the lateral lucency. And then insert the cement into is the peg hole for the female side. And final impaction, and then insert impaction, and then insert the trial and make sure that the size is the perfect, and then insert the real component anatomical bearing. That is this is the end of the operation. Okay, this is the review of the step of the procedure. Okay, the next my talk is dislocation, bearing dislocation, because dislocation is quite a serious problem after the Oxford knee. So some surgeons prefer to use a fixed bearing to prevent the dislocation. Dislocation is very mysterious. Even the skilled surgeon, experienced surgeon, that this bearing dislocation can occur. Okay, so shall we start my talk about the dislocation? Oh, this is sad to see. This is the posterior dislocation and anterior dislocation. I don't want to see this one. So this is the cause of dislocation and its prevention. Uh, the one cause is the distraction. In other words, in the large joint gap. So that can cause by the incorrect balance. So to prevent this, you should make sure to adjust the gap accurately. The second one is the stretch ligament that can cause, that means the over tension of the MC. Some surgeon, especially for the beginner surgeon, due to the worry about the dislocation of the bearings, they tend to insert the thicker polyethylene, thicker bearing to prevent the dislocation. But in result, to overstretch ligament can cause abnormal stretch of the MCL, dysfunction the MCL. That can cause the looseness of the medial side. That can cause medial side looseness. So please avoid overstep. Now, ideally, is for example 3 millimeter filler gauge inserted very smoothly, but 4 size filler gauge is inserted is very difficult, very tight. It is ideal. So the feeling of the filler gauge is light, no friction is normal. If you feel some friction, it implies it is overstiff stuff. So never overstuff. And damage ligament. This is the basic error, fundamental error during the sidal cut of the bone, both femur and the tibia side. So protect the PCL, and again, you should check the position of the cutting surf, cutting plane, and position of the retractor before the cutting, before the using the saw. And the second one is the displacement. Displacement can be also force from other object. For example, bone, cement, or meniscus. In the deep friction, if there is the big osteophyte or thick remnant meniscus, that can push the bearing anteriorly, that can cause a fracture. And of course, there is the cement, the posterior side of the tibia trend that can push the bearing anteriorly, that can cause anterior dislocation. And in the same time, if there is some bone on the anterior edge of the femoral component that can push the bearing posteriorly, that can cause the posterior dislocation. And bearing position is very important. So separation, that means the bearing is separate from the lateral wall, that can cause a spinning of the bearing, that can cause dislocation, especially for the posterior side. And by contrast, in the wall hitting or the bearing can cause the bearing rotation. If the bearing hit the lateral wall, the bearing can pop out. So keep a proper space, ideally to keep 1 millimeter space between the lateral wall and bearing throughout the ROM, from the full extension to the full flexion. That is the idea. But this is depend on the sighted cut position and the direction of the sighted cut. It is quite a difficult question, and nobody know the true answer. So, if this femur component implanted too medially, that can cause the lateral dislocation of the bearing. And by contrast, if the femur component is implanted too laterally, the this bearing can spin in 19 degrees. So if the bearing rotates 19 degrees, the height difference, in other words, the height jumping height is only the 2 millimeter in the both sides. It's easy to dislocate. So otherwise, in the normal situation, anterior edge is 2 millimeter thicker, and the posterior side is 3 millimeter thicker than the thickness of the bearing. So this is a treatment. Manipulation is sometimes the possible. So especially for the anterior dislocation, in the some posterior dislocation. So if you find dislocation, please try the manipulation and the fluoroscope, the full flexion, and then full extension. Sometimes after the full flexion and then extension fully, you can find the bearing is reducted naturally. I will show you this one. This is my previous case. This is the dislocated bearing in the posterior flexion and the flexion, deep flexion. At that time, I applied some beta stress, sorry, valgus stress, and flex deeply, and I feel the pop. Then reducted, and this anterior side, I made sure the bearing is dislocated. So before the planning the operation, I strongly recommend you to try the manipulation under the fluoroscope once. We don't need the anesthesia. If it is impossible, the next step should be the open reduction and remove the bearing and identify the cause. Sometimes there is some big osteophyte or remnant meniscus to the posterior side In this case, you should remove them and then change to the new bearings. Never use the same bearing because after the dislocation, this polyethylene is damaged more or less. So please change. Use the same thickness or 1 millimeter thicker. So, but if it is impossible to balance, adjust the balance, we need to use the fixed bearing or totoni to change to the totoni. Okay. So, this is a very unusual case. This is a far posterior dislocation, extra articular dislocation case. Uh, I couldn't find the bearing intra-articular space, so I make sure the position of the bearing using the flow solved. I found this is extra-articular to the within the muscle. So I open the incision to the lateral side and take it out using the forceps like this. This is the maybe twice or third times dislocation. So this bearing is at 6. Even using the 2-6 bearing, this patient dislocated posteriorly and outside of the joint into the muscle. So sometimes bearing is by the separation can occur. So I recommend to check the relationship between the tibia tray and bearing before the keel preparation. Using the bearing trial bearing, put on the keyless tibia trial and female component trial and insert the trial bearing and make sure the space between the lateral wall. If this is the space is too wide, so insert something, for example, the rod or a chisel or some plate between the cital cut plane and lateral wall of the tibia tray. Like this, we can see some space between lateral wall and lateral cutting surface. And I inserted this space, this rod. This rod can make the space between the bone and lateral wall and fix this tray by pin. And then make sure the space is shrinked. So this is ideal, not only the 1 millimeter. Then make the keel and fix using a cement. The space between the lateral wall and the lateral cutting surface, I filled this space with cement or bone tips. Okay, this is the tip of the prevent the dislocation. By contrast, if at this time, if you find some wall fitting or the bearing, you should recut the lateral cut before the preparation of the keel. Okay. Okay, thank you for coming. This is the end of my talk. If you have some question or comment, please send me the email or messenger or something. Okay, next week I will talk about some case. If you have some interesting case or very problem case, please send me. I will discuss on the web in the next week. Otherwise, I will prepare some interesting cases and I will show you. But I want to talk about your case. Your case using your case talk about and let's find the good solution for the problem. or predefine the cause of their problem. So to prevent the same complication in the future. Okay. Okay. Thank you for coming. Thank you, friends. See you next week. Please come. Thank you. Goodbye. Good night. Have a good night.